So we will go to the first talk. That's my talk. It's just talking about it was very hard to talk about 14 years ago where to start, and now it's equally difficult to talk about where to start because there's so many options. It's like an embarrassment. Uh, Partly because we have so much, partly because we still are trying to figure out how to utilize that and find the right people and create the best therapy for them. So we'll talk about novel approaches for the initial management of advanced melanoma. I did say that I will use the timer. That reminds me to thank the most important person that has ensured that this meeting goes off without a hitch and without a lot of involvement here. That's Connie Doe. Connie is great. She could run this and set this up without me. And that's my greatest fear. Oh. Next year, I won't be invited back. She'll just say, you didn't do it. You didn't keep up the quality. All right. So those are, I love this conflict of interest slide because it just shows really how many people are there fighting with us, how all of the pharmaceutical companies who are working and are listening. I mean, you can take my picture out of there and put every other medical oncologist picture in there because we now have a voice and we talk face to face. Oh, I usually steal a lot of slides from Dr. Sullivan, and this is my favorite because it shows us how many agents we now have approved and where we have gone. When we started in 2010 with this meeting, we didn't have anything standard. We were talking about FDA thinking about approving this thing CTLA-4 that had a low response rate and possibly a lot of side effects. We didn't know what to do. So the talks were easy. You could just say whatever you wanted and you didn't have to know much. You could just talk about what's in clinical trial with no data. And there was this sense of tension. And now where we're here, we have just gotten more and more approved, and you'll see where it's going through these talks. When we give these talks, we try not to have slides that are too busy, but the main idea of why immunotherapy has come to the forefront is we found out how to take this T cell, the major immune cell that's hanging out in our bodies that causes inflammation and all these autoimmune diseases, and use these activating receptors, which are, you stimulate them and they cause that T cell to go into overdrive, or you block an inhibitory receptor, you take the brakes off, and you allow these cells to recognize tumors as foreign, just like they would recognize a virus as foreign. And we found that as immunotherapy, we become resistant to it, or if it works and then it stops working, or if it never works, there's this idea that we need to maybe target more of these or find out how to, when and where and how to target them to move forward. We've understood that, anti-CTLA-4, this Yervoy ipilimumab, can work in one area and some can work in the other. So initially in the lymph nodes, and then distantly when the T cell comes to the tumor. We've had multiple studies looking at that, and now we've come to a position where we have so many options. We need to now take a step back and understand why something works so good in our young female patient and doesn't work as well in our older male patient or the other person that comes through. It was easy to do simple trials in the past because let's put X and Y together. We only had 3 things in the toolbox, but now we have to take this idea of looking at complex. So what do we now know? This was the checkmate study of ipilimumab, nivolumab, and it is the pinnacle of what you want. You want a study that takes a median survival, that's where 50% of patients have succumbed to a disease, from 6 to 8 months and turn it into 6+ years. And clearly what you see on the left is where we were before, pre-checkpoint, pre-BRAF therapy. And what we have on the right is this idea of a survival curve. These are survival curves. So it starts at 100, everyone is here in the room, and slowly, unfortunately, becomes less and less. What you'd like to see is these curves going higher and higher, like you see here. You have this, and you have this, you add something on it, up, and then you'd like to see this thing we call a plateau. And the plateau is really easy. It's something you learn in like 3rd grade math. It just hits and it becomes flat. And that means that you are taking people to from a concern to a long-term survivor. And we see this with immunotherapy in multiple solid tumors. Unfortunately, it's so much lower than in other solid tumors. And as we figure out why this is like this in melanoma, we can take it to other solid tumors. We've also understood that possibly higher doses of some of our drugs are helpful. I put this up all the time, but if you look to the left, the difference between lower dose of anti-CTLA-4 and a higher dose is a significantly higher toxicity. That's why we don't really give the 10 milligram dose. But in the long term, as a single agent, it is better. Now, in combination, you might not need that. But what if you could get it to get the best of both worlds? Have a Yervoy-like drug that doesn't have the same toxicity, so you can dose it higher and higher and higher. These are the questions that we're trying to answer for you. I mean, not for you, because as I look around, there's a lot of long-term survivors here, but for everyone. And also, this will be like my only adjuvant slide, but in those patients who show up with a single area of metastatic disease and then we take it off, do we really need to do something, and how can we improve it? And this shows that combination really does that. You can see that it goes higher and higher and higher as you add an anti-CTLA-4 and an anti-PD-1, as you add Yervoy to Opdivo, things like that. Well, what else have we learned? And this is something that I love to speak about, is we've learned that it's not just good enough to get people to a control of disease. It's good, but it may be better to get them so that all of the disease either goes away or it doesn't show up on a PET scan. These are progression-free survival. That means how long you control the disease based on your response. So the CR is a complete response. That means everything is in the scans are gone, or in a PET scan, it doesn't light up. Partial response is you get a major shrinkage, but not fully. And you see, as you go in time and time and time, yes, you see a plateau, but it's great to get control. It's not the most optimal. And that's the same as if you look at it for overall survival. These are a combination of anti-CTLA-4, anti-PD-1 versus each single alone. And you'll see that it's true for other combos additionally. So the next step for us for some of the early first-line patients is, look, we have controlled your disease. Everything is gone. Your PET scan is still viable. It's still lighting up, or we haven't gotten the best. How do we add things on, whether it's radiation or surgery, to get you to the place where we can move you up from, coach to a premium to first class response. We have 2 people flying out today. I'm just going to talk their language. And so as we have gotten more and more experience, we do find little nuggets, right? We take these trials and we look at 1 year, 2 year, 3 year, we continually present them, and people say, why are you continuing to present this? This is just the same thing I saw. But if you look at the tail of the curve, where on the bottom left, those are the plateaus we love. But what comes from this, and this was just presented at last year's big meeting, is that if you get to a durable benefit at 3 years, that points towards a melanoma-specific survival that's over 95%, right? So these first 3 years are key. And so that's where we're going. Okay, what else? When is the big question, if you have a BRAF mutation, which a lot of people here do, and a lot of my patients do, and we never utilize it, there's a targeting of drugs that target that mutation. But should you start with this or the targeted agents or the immunotherapy? Well, we've looked at that now and found that these are response and overall survival. We found that the blue line, where you start with immunotherapy, is the most important one. And this is a paradigm that holds for melanoma and may not hold for other solid tumors. But as we get better immunotherapy, these will become questions for other solid tumors. It's also a question, if you see initially that overall survival is orange, and then the blue starts to tick up. What do we do for those people? How do we identify those people? What are characteristics for them where we can say, all right, you're not an immunotherapy person? And so that's coming into our paradigm. We never knew that until we did these studies. Additionally, if you look at this again shows you that even with targeted therapies, we need to get deeper, better, bigger responses. Right? That's a big LA thing. Bigger, bolder is important, and it's important here. A good friend of ours, Paulo Cierto, looked to try and figure out how to help these people, on the right, where the orange is targeted therapy, helped that population better. And so he said, well, let's not just continue the targeted therapy. Let's start with a little burst, control disease, and go to the immunotherapy. And he did that, and basically showed that in those patients who have aggressive growth, they need those targeted therapies because they work so much faster, but you don't need to keep them on it until the tumor becomes resistant. You need to bring in immunotherapy earlier. So these paradigms are important. How about toxicity? When we talk about combination, where toxicity gets greater, and we talk about side effects like colitis, and nobody likes to have that, or the rash, and nobody likes to have that, or the diabetes. And so we're looking at novel combinations. This was a combination where we just flipped the dosage in a certain population and showed that the side effects profiles is less. So we're looking at how to manipulate therapies, not only to get the side effect profile to be less, but also maybe add something that can increase our responses and benefit. A lot of you have heard about the LAG-3 PD-1 combination, and this has come on. It's now given us another combination that looks great. We're not quite clear how it works in certain subpopulations of the most aggressive. I see a patient saying, like, why didn't I get that? Well, we still don't know how it works in patients with initial brain mets, where the other combination has been around longer, or bigger disease, or BRAF disease. And this was the same way, looking at that combination of LAG-3 PD-1, so the relatlimab nivolumab versus the PD-1 alone. We showed that progression-free survival is better. Overall survival, not statistically better, but some indication that it's better. But what I like about this here is that it proves the point of immunotherapy. And that's, if you start looking at 3 years, you're now seeing that plateau we talked about. And it's an indicator to me of a therapy that has promise, that works, that we can look at. And again, it became like, how can I say it? It became like Coke versus Pepsi, Coke versus Pepsi, Coke versus Pepsi. And as you'll see, we found a way to sort of say, let's mix it all together and get a better drink. Here is now early data from that trial showing that when you combine, that you get better control of patients everywhere. The incidence of brain metastases, which is something we try and avoid, is less in people who don't have brain metastases and see combination. So this is another reason we're looking to move to combination. Again, now we are now building an infrastructure to say that, again, getting a complete response is better. Is it better because those people had some better characteristics, or is it better because same people with same characteristics, the one that gets a CR, a complete response, does well? Well, it just, for me, is let's get them to complete response. Let's look at trials that add things on for a person who's had a good response to get them to a deeper, better response. And some of those trials are coming. We have one opening with something that takes care of regulatory T cells. But we're also understanding that the tissue itself is helpful for us. Looking at how much PD-1 is expressed. These are things that you hear about. You have a low PD-1, well, low PD-L1. What does that mean? Really is indicating to us that you may need a combination rather than a single agent, because some of these combinations outside of the United States are only approved for people who have a low PD-L1, where a single agent may not be as great. But also, when you look at this is not standard, but it came from this trial. If you had a low LAG3 expression on your cells, you did not do as well in progression. The benefit was equally strong, but if you had a low level, you are someone who is going to progress very rapidly, regardless of what you got. And through some of the work that Dr. Memi is doing, we're going back to look and see if we could figure out if those patients who had low lag expression did this poorly or did much, much better if they got like an anti-CTLA-4 regimen. So possibly that's important and possibly not, because I don't remember where my slides are, but we're trying to look at these head to head. You don't need to write any of this down. I was one of those students. I had to write everything down, and the slide would move too fast. But the whole thing about it is that we're now looking at subgroups, trying to understand who does better, because we could never go and do another big, huge trial, 3 arms, head to head to head. And we're looking at things like hazard ratios. How did you do on this trial compared to just a single agent? How did you do on that trial compared to single agent? And then we can sort of do a transitive look at it. Okay, what else is coming on? We're now through this idea that we need to move away from these checkpoint inhibitors. Yeah, it's great to make a good it's great to make a good blouse, but you can't just build a company on just making blouses. Let's make some other things and build our our immunological brand on other therapies. And how can they help? For a long time, we have known that there are hot tumors and cold tumors, and it's really hard to come to an understanding of how to explain that to patients if you start to delve into all of the data. It's just that you don't have enough T cells in your tumor. Those T cells that you're trying to agitate with your therapy are not there. So even if you can agitate them, it's not enough. So some of these newer therapies we're looking at are, are important. But even as we move from there, we're also trying to improve some of the lag therapies, some of the checkpoints. And this is one where we've seen a higher response rate with a lag inhibitor and a PD-1, and it's going in randomized 3 trials, but possibly it's because we were giving higher doses or more frequent. We don't need that. Sorry. So how about predictors of poor T cell response? How do we agitate those T cells? Well, predictors of toxicity, and interleukin-6 in the serum has been important there. Interleukin-6 is a thing that caused COVID lung. Okay, it's easy to understand. It's an immune flare. It is causing off-target side effects and toxicity. And through work that same Checkmate 67 Ipi-Nivo trial did, we found out you did poorer if you had higher levels of IL-6. So associated with shorter overall survival. So how do we target that? Well, as you'll remember, there was a drug that targeted IL-6 that was used for COVID lung. We use it for patients who have a huge immunological flare. And some people decided to say, let's look at it earlier and earlier, even in first-line patients. This is a trial done at MD Anderson, where Dr. Patel worked as she transitions to a new place, but it added that drug, tocilizumab, into combinations. And what did we see? It increased immune cell infiltration, decreased the incidence of side effects, and may increase response rate. And we've done a similar trial here. And now we're looking at this trial. And this trial is a huge jump. The huge jump comes from the fact that I didn't talk about putting together CTLA4 PD-1 and a LAG-3 inhibitor. That's been done and will be presented in less than a month at our big meeting. It may have higher response rates, and that's what we've seen. It may have higher side effects, right? As I said, if you add 1 + 1 is 2, but it's a higher side effect profile. 1 + 1 + 1 is 3. It probably has a higher side effect profile. So we decided, not me, but Dr. Weber at NYU and a trial that we're doing here and there for first-line patients, let's add everything together, everything in the toolbox, and an IL-6 inhibitor to decrease the incidence of side effects, maybe increase efficacy, and this is currently accruing. We talked about the anti-CTLA4 drug ipilimumab, known as Yervoy, and how the 10 milligram dose had so much toxicity. The toxicity was that it was going not where the tumor was, it was going to where normal tissue was, like your colon, like your pancreas, like your pancreas. And it was inflaming. So there's a drug that we're looking at in clinical trials. It's called conditionally active antibody. So when it gets into a acidic environment, like where the tumor is, it's active. When it goes into a non-acidic or less acidic environment, like your colon or your pancreas, it's inactive. Just basically is just on the lazy river going to when it gets to the tumor. And so that's great. What about the first line? So this is now, we've gotten to doses that are tolerable, and the doses that we're looking at in combination now, the 700 milligram dose is thought to be equivalent to the 10 milligram per kilogram dose of anti-CTLA4. And we are not seeing the same incidence of other toxicities. We're seeing some cytokine release. And we're combining it with an anti-PD-1, that nivolumab that you guys know as Opdivo, at a 240 milligram dose, at a full dose, not a third dose that we utilize in our combination every 3 weeks. So higher dosages of both, hopefully. And this is now in a first-line trial here. So that's fine. We've only seen 2 patients with immune-related adverse events that are high grade, whereas we should have seen more. But also, what have we seen in it in the combination? We've seen great responses in other solid tumors. And our 2 people, the cervical cancer patient here is one that we treated here, had everything go away. So that's very rare to see. And we hopefully some of these, as the trial accrues more, got to run through. So it's now looking at a melanoma. What we've also seen and what prompts us to look at improving is in our trials of now going and doing some of these combinations after you've already seen a PD-1, we see very low response rates, very short control. So bringing it all earlier is better, possibly. Again, you can skip over that. Let's talk about vaccines, because that's so big now. You've heard about the vaccines and you want part of it. This is a vaccine that is off the shelf, that comes from a company, IO Biotech, that is a vaccine to 2 proteins found on your tumor cells. And basically, you're giving it along with the PD-1. You're priming the immune system because the T cells see that vaccine, they target the tumor, then you boost. And initially, early on, the initial small study of this in first-line patients showed something very interesting, an 80% response rate. That's one of the highest response rates. And the academics sitting in the front row here will say, well, that's a small study. It's only 30 patients or so. That's fine, but it had a 50% complete response rate, and I like that, right? We've started saying the complete response rate is great. So when you see this, you say, that's great. It was very tolerable, not a lot of side effects. It's a combination. I'd like you to do a big study, randomizing hundreds of patients, and tell me how it shows. And it's been done. This is accrued and will be presented within less than a year. So we'll see how that works. Hopefully we'll find something on how to bring a vaccine in, because it is an easy thing to combine with low toxicity. Okay, now this is what I was talking about, bringing in the T cells. And these are ImmTACs, which are like a double-sided antibody here. One side brings the T cell in, the other side targets a protein on the tumor. And we've shown that this has been successful in the hardest melanoma to treat, ocular melanoma. The first drug approved was a drug that we had in phase 1, small studies, big studies, it randomized, it showed significance. But now there are other drugs like this, and this is the targets a protein PRAME. Again, PRAME is on 90% of melanomas. PRAME is also on endometrial, non-small cell, triple-negative breast, small cell lung cancer. So there is a lot of tumors that this can help. This is how it really works. It brings the T cell next to the cancer cell, sort of like a matchmaker. And then they get together, they fight. The T cell wins and destroys the cancer cell and moves on. And we have seen this in the trial, that once you give it, it causes the lymphocytes, your T cells in your blood, to fall down. Where are they going? They're being trafficked into the tumor. You can see pre-treatment, not a lot of purple, and then post-treatment, as we biopsy patients, a lot of purple. And it is showing great responses. We'll be talking about that at our big meeting in less than a month. And it's already being looked at in a first-line trial in the randomized fashion, right? So people will be getting a PD-1 inhibitor plus that ImmTAC that's bifunctional antibody versus a standard therapy. And this is hundreds of patients, 650 patients. So for those of you out there zooming in, I think the point to take away from it, even if you have done well, is to talk to those patients who come to you and say, what should I do? Where should I go? Find a place that has expertise. See if you can benefit from some of these trials. See if you can benefit from the expertise, and allow that oncologist to work with your local oncologist to make plans. And to make plans doesn't mean listen to the talk that you're hearing now, but to listen to the second line talk, listen to the TIL talk, and try and bring that into your treatment plan. All right, I'm running out of time, but these bispecifics can also work in a way where we can make them so they can cycle through different proteins. So once one stops to work, we can give another one to continue to bring those T cells in to recognize difference. I won't talk a lot about TIL, but we'll say all of this lovely data in the second line you heard that led to its approval. And the idea that it works in other solid tumors has already gone into a first-line trial. Early data in the first line shows good response, very small numbers of patients, but Tilvance is accruing now, which is just a standard PD-1 versus getting TIL and PD-1 earlier, the first therapy that you get. Dr. Ferries is going to give you a great talk on that. No one's going to talk about poop after this slide, I promise. But this idea of trying to change your flora. If you get colitis, we've already done that. We're changing your flora, but in a good way. It's coming out, and there's been some early data that could work. It's a lot of work to change the flora and the fauna in your gut, but very interesting stuff. More to come, hopefully, in our when you come to the 20th year anniversary, we'll figure out how to have figured it out. NK cells are cells that you've never heard about, really. There are other immune cells that are out there, and they're just hanging around. They're like that person on your basketball team that always gets in and never takes the shot, never defends. You hear about it, it's there. And you're like, I need to figure out how to utilize this person on our team. And this is where a lot of our research now is going, how to utilize these NK cells in melanomas. I love it. And we have antibodies that are like checkpoints for NKs that are in our clinical program now that stimulate the NK cells. This is a great one. That's off the shelf NK cells that come from other patients that are ready to give. We don't have a lot of experience in melanoma with it, but these are patients who failed in sarcoma, the hardest cancers to treat. And this is an off-the-shelf allo NK, which means you can just utilize it while you're waiting for your TIL to grow or once it's something else. And it has shown responses in heavily pretreated sarcomas. And I think the bottom one was a lung cancer, but we have more to come from that and some of the other academic partners that are getting into that. So as I come to a close, I will say that this is my favorite meeting of the year, not just because I get to see everyone, but I get to drag these two people with me and we get to hang out for a dinner and to talk and actually have had the wonderful, wonderful ability to steal their slides and hitch on to the work that they're doing. It's great. You'll never find a picture of me with them without a big smile, I will say. And then I will thank you